All right, welcome everyone. Thanks for showing up today. Hope you had an easy commute in given the accident. I would like to remind everyone that there is no food or drink of any kind. Water, coffee, etc. is not allowed in the auditorium. So if you do have a container, please don't open it while you're in here at all. And I'd like to give a special thanks to the Sanford Burnham Prebys Medical Discovery Institute for the use of their auditorium. And since Samir already slipped out, but Samir Cohen makes sure that we get into this auditorium and make sure we have this at our disposal on the third Saturdays of the month. She does a great job helping us out with this, and so special thanks to them. The principals of the organization are myself, Aaron Lamb, director, facilitator, and currently the temporary president. We have Jean Van Vliet, a director, Bill Manning, our director and videographer, John Gottlieb, our treasurer, Steve Pendergast, here in the front row, secretary and newsletter editor. John Tassi is our webmaster. Bill Bailey outside, our librarian. And we have a number of other volunteers to the organization that have been stepping up in the last few months. Thank you very much to them. And of course, there is all of you, well over 900 members. Everyone is a volunteer, and you can be too. Are there any newcomers here? People here for the very first time? Okay. Keep your hands up, please. Mike is going to come around and give you a newcomer packet. I think actually, if you have already received it, go ahead and put your hand down. But this is an information packet for you. Please fill out the cover sheet and bring that back to me here at the podium before you leave. That will get you into our database if you're not already in there. Right now, we're not really doing welcome calls. I don't know if, Jean, you're back up for doing that yourself, but we are looking for volunteers to the organization that are willing to call newcomers, discuss their situation with them, help them understand how our organization can best work for them. So please do contact me if you're willing to do that job. We haven't done this too much recently, but let's have a little survey here in the audience in terms of how long you've been dealing with your prostate cancer. Who is here? We did see who is here for the first time. Who has been recently diagnosed? Go ahead and raise your hand. Yeah, some new people to the show. How many have had prostate cancer for less than 1 year? Go ahead and raise your hands. 1 to 4 years. Yeah, quite a few. 5 to 10 years. Yeah. 11 to 15 years. Look around. There's a few of us, yes. And longer than 15 years.
23.
Yeah. Anyone beat 23? So especially for you newcomers, do realize that this is a type of cancer that is, as the very first slide said, it's prostate cancer is 2 words. It's not a sentence. You still have a long life ahead of you. There's much to look ahead to in the future, and it's very possible that you can live with this, have treatment that allows you to live with this for 20 plus years. Now for this next survey, look around the room and see who raises their hand. And if you are looking into this particular treatment, those people that raise their hands are the key people to walk up to later on and say, hey, tell me your experience with this. I'm going through this right now. I'm concerned about this, that, and the other thing. And have a chat with those people during the lunch afterwards. Who is on active surveillance? Who's had surgery? Quite a few. Who have had radiation?
Could you differentiate between proton, X-ray, and BRAF?
Sure thing, sure thing. Who has had proton therapy in particular? Okay. And who has had X-ray, IMRT, SBRT, so forth? Yeah. And who has had brachytherapy? Okay. Who has been on ADT and hormone therapy? Quite a few of us, very common. Who's had chemotherapy? Who's had other new treatments, specifically focal? This is becoming a more widely prescribed treatment earlier on. How about immunotherapy, like Provenge? Okay, a couple of us. Xofigo? Pluvicto? Gene, is your arm getting tired? And how many people are dealing with recurrence, where it has been treated, it's gone away, and now it's come back, and we're now undecided for future treatment? Who is undecided for future treatment? Yeah, that's why a lot of people are here today. Okay. We are working on an online survey. I know I mentioned this last month. I had promised to get it done before this meeting. I did not. But in the near future, hopefully we'll be sending you a survey that you'll get through the usual means. And I please ask you to fill that out to your best effort. It will do wonders for guiding this organization into the types of speakers that you would like to see in the future. Hopefully it will find other very interesting treatment journeys people have been on that they would like to share with the group. And we are, of course, trying to maintain HIPAA requirements for anonymity and so forth. Our support to you comes in the way of our website, which I'm sure that you've all seen. Perhaps less seen is our YouTube channel, Prostate Cancer Support, where you can find video recordings of all of our past meetings. This is an extremely useful resource to go to, especially for those newcomers. You can search for various treatments that have been discussed, imaging and diagnostic techniques that we have covered. Perhaps most importantly, there are chapter markings, so you can skip through to the beginning of where the doctors actually speak and not have to listen to me every video. And our meetings are on the third Saturdays of the month, except in December. Hopefully you're all getting the newsletter by email. You can also access those, download through the website, and we frequently have copies of printed copies of those newsletters out on the tables just outside in the other room. We do not actively, as I said before, have the hotline calls running, but we are looking for people that have had a bit of treatment already, that are willing to listen to other men that are recently diagnosed, recently joining the group, and help to guide them find the information that they need to make their own best decision. Are we hearing the theme yet about needing some more volunteers? Especially for you guys that held up your hands when you said that you were looking for future treatment and not sure yet what you were going to do. You are the ideal candidates for helping us find new speakers for our monthly meetings. Bill Lewis did a fantastic job of finding signing up our recurring speakers, as well as finding new cutting-edge research and bringing those researchers in to speak to us. We really need some inquisitive minds that are looking at whether it's medical articles, seeking out new doctors, whatever it might be. Please email me. There's my personal email address. Make sure the subject says something about IPCSG volunteer in it. Let me know that you're willing to volunteer for this or anything else. We are also in need of a backup facilitator for myself, newsletter assistants, as I said, taking the hotline calls. Now, specifically, our support group purpose is we share patient-focused experience on becoming your own case manager through informing, networking, and caring. We are a group of experienced participants, but we are not medical professionals, and any sharing by anyone of our group may not be a substitute for your own medical counsel. And we do need your support. I'm going to pass around some baskets. Can I get a volunteer to pass along the baskets here on this side here? Yeah, thanks. Thank you. We are a 501c3 nonprofit organization, so donations are tax deductible. We have no medical or religious affiliations, and our largest costs are our website, advertising, mailings, the video recordings, and et cetera. So please do make a donation today. If you can't make that donation today, the preferred method is to send a check to the IPCSG at the PO box that you see there. You can also use the PayPal link online. And I would like to thank everybody for just many generous donations. There was even somebody that walked up and handed me a check at the last meeting, and I didn't even have a chance to acknowledge how generous that donation was. Including, I know that one of the people that helped out Sparrow Search last month, they donated their honorarium to the organization as well. Just, thank you very much for everything that you do. Next month, a very recent development is we're going to have Dr. Rajiv Chopra. I'll handle it. From Texas Prostate, he'll be talking about the Tulsa Pro technique. That will be for April. You might have remembered that I previously said Dr. McKay was going to be here next month. She's had to rearrange some of her travel, and it now interferes with her ability to attend. We will reschedule her for later in the year. In May, we are going to have Dr. Begrosia from UCSD Urologic Oncology here. And I am also still working on getting the various patient navigators or nurse navigators from the different organizations here in town, specifically UCSD, Scripps, and Kaiser, to come in sometime later in the year. And we really think this is going to be an excellent meeting for you to help understand how to navigate these different systems, especially if you want to perhaps get a second opinion. If you're within Scripps, want to get a second opinion at UCSD. Some of these are complicated situations that these nurses can help direct us into understanding how to achieve. However, for today, we have Dr. Richard Lamb, Research Director at Prostate Oncology Specialists up in Marina del Rey. He's going to give us updates on the latest trials, testing, and treatment for prostate cancer. You might remember Dr. Lamb being here many times to this organization. He is a mainstay of our speakers, and he is a double board certified internist and oncologist who has dedicated his career to the specialized treatment of prostate cancer at Prostate Oncology Specialists since 2001. So with that, Dr. Lamb. All right, yeah. As always, please try to keep your big questions to the end of the meeting. I'll run around with the microphone and we'll handle them then. Thank you.
Good morning. Good morning. I think this is like my 15th or 18th time. 17th. 17th. Some in the teens, yes. So it's always a pleasure and honor to come here. I'm usually very proud to come here because you guys are such a successful and big group. Despite COVID and changes in the whole system with internet and everything, being able to see so many people in person is it's inspiring. So with that in mind, let's get started. So my topic today is, I usually try to give you guys an update every couple of years on what's new in the field. So today, that's what we'll do. So we're going to try and talk about these topics, including new targeted therapies, radiopharmaceuticals, combination therapies, immunotherapy advances, minimally invasive options, some diagnostic innovations, and we'll talk a little bit about artificial intelligence, since that seems to be the buzzword nowadays. Pretty soon, you'll have a robot lecturing you guys. And okay, so let's talk about targeted therapies first. The old classic OG target for prostate cancer is the androgen receptor. So that's the, we target that receptor with various medications for the last 40 years. It's all related to blocking the hormones in our body. So we call that androgen deprivation. Some people call it hormone blockade. And there's lots of drugs that work on that target. There's some new targets that we're going to touch on today. One is the PARP enzyme. It's an enzyme that plays a role in DNA repair of the cancer cell. So when the enzyme basically is good for the cancer, so we want to inhibit this target, so that would be bad for the cancer. So these are three drugs. There's a fourth one actually that just got approved. You notice they all end with the two letters IB. So that's olaparib, rucaparib, talazoparib, and niraparib. So all these drugs are called PARP inhibitors, and we'll talk about how it works in a second. Another target is the PSMA, or prostate-specific membrane antigen. This is a molecule found in most surfaces of most cancer cell surfaces, but not all. So we're using what we call radiopharmaceuticals to target this PSMA molecule and deliver radiation to the cancer cells directly. And the FDA-approved drug currently is called lutetium-177. Some people have heard it as Pluvicto. The next generation radiopharmaceutical is called actinium, and it is currently actively being studied at multiple places. UCLA among them, possibly Hoag, and maybe UCSD. Oops, let's see here. Here we go. Okay, so let's go back to this. This slide is, I'm going to talk about PARP inhibition, but let's talk a little bit about the androgen receptor target, the original target that we use. So let's look at this, this green box here. We call it the androgen receptor. And when testosterone, dihydrotestosterone, they're all related, male hormones, in the bloodstream go onto the androgen receptor. This complex, the AR testosterone complex, goes into the nucleus of the cancer cell, attaches to the DNA, and blocks the DNA from replicating. And when the DNA stops replicating, cancer dies. So this is the typical approach we use for prostate cancer. And on this androgen receptor pathway, there's various drugs that inhibit this pathway. One drug is Lupron or Orgovyx, or in the olden days, chemical or surgical castration. So that basically removes testosterone from the body. There are other ways to remove testosterone from the body. It turns out that cholesterol gets converted to testosterone. So by blocking this, there's an enzyme that converts cholesterol to testosterone that's called CYP17. So that's how abiraterone works. Zytiga, abiraterone, it works by blocking the conversion of cholesterol to testosterone. It turns out that abiraterone works so well, even in the testicles, a lot of people who take abiraterone, we could even stop Lupron. So that's a take-home message. Unfortunately, lowering cholesterol hasn't been a very successful option. So if you think about, oh, if I lower the cholesterol, I should lower the testosterone. That should be good for cancer. It turns out it's really difficult to lower it to so well that there's an anti-cancer effect. But potentially, there's people who've been taking cholesterol medicines for a long time. They seem to have better outcomes and better statistics with regards to prostate cancer. So potentially there's a connection between statins being good against prostate cancer. That's the mechanism. Other ways to block the AR testosterone pathway is preventing the testosterone or dihydrotestosterone from attaching to the receptor. So it blocks the red dot attaching to the green box. And we use many drugs such as enzalutamide, darolutamide, apalutamide, or in the olden days, Casodex, bicalutamide. These are all AR receptor blockers. So these are another way. Yeah, that's about it in terms of blocking the androgen receptor complex. So when the androgen receptor complex hits the DNA, it turns out that this PARP enzyme helps the DNA replicate. So if you use PARP inhibitors, it actually is another target to block the DNA from replicating. With me so far? Okay. So unfortunately, PARP inhibitors have been studied, and it only works in certain patients. And this applies to breast cancer, ovarian, and prostate cancer. This drug works for these three cancers primarily. And if you have these three cancers, you also need to have mutations in the homologous recombinant repair genes. And these genes are these genes here. So if you have these mutations in these genes, then you can consider PARP inhibitor. In prostate cancer, it turns out that in advanced cases, about 20% of men will have these gene mutations. So 1 out of 5 men may use these PARP inhibitors. And if you use it, there's alone, as one drug, about 1 out of 3 men get a benefit. If you use it in conjunction with the classic AR inhibitors, it basically, when you combine these drugs with enzalutamide or abiraterone, it improves the response duration by about 100%. It doubles the duration of benefit. How to test for these genes, we'll talk about that a little bit more later on, but there's 2 types of testing. One is germline testing, and one is somatic testing. The other target that we're going to touch upon today is the PSMA molecule. So this molecule is found on most cancer cells, as I mentioned earlier, and the drug that's been approved is lutetium, Pluvicto, and it basically delivers radiation to the cancer cells. This drug is currently approved for people with metastatic castrate-resistant prostate cancer who have had chemotherapy. So I use the word have had chemotherapy, meaning you could have had it, it didn't work. You could have had it and it worked, but now the cancer's back. Or you could have had chemotherapy and you stopped because of side effects. So the criteria is pretty broad. You just have to have a whiff of chemo to qualify for Pluvicto. Okay. So it has been shown so far to improve survival in these men. It works in about 60% of men who take it. And when it works from anywhere between 4 to 6 months, which is so-so, but it also works up to like 2 years. So it all kind of depends on the luck of the draw. It's fairly well tolerated. It has, it basically goes wherever the treatment's injected into the veins, and the side effects are related to wherever this drug goes to. It goes to your parotid glands, so one of the side effects is dry mouth. It goes to a little bit in your intestines, so some people get nausea. And it goes into the bone marrow, so one of the bigger side effects is it could affect your red counts and white counts. And one of the rare side effects that we've discovered recently is it could really hurt the kidneys. So, not every drug has potential side effects. So they are studying this drug in combination with other drugs such as PARP inhibitors, AR receptor blockers, and possibly used before chemotherapy. The newer version of lutetium is actinium-225. Basically, it came out about 3 years after lutetium. All this started in Europe. So lutetium came out in Europe in the trials about 10 years ago. Actinium came out about 7 years ago, and it just takes a long time to work its way through to the trial process. But currently, we know that actinium is stronger than lutetium, maybe 100 times stronger. And we also know that the alpha particles that actinium is, it doesn't spread the radiation too far from the cancer cell. So hopefully it has a smaller area of damage. So currently it's being studied after lutetium. So hopefully there'll be, once it's approved for after lutetium, then the next step is typically the researchers will do it in comparison to lutetium. So all these things take years. Hopefully in about 1.5 to 2 years, we'll have really good data, and it might get approved at that time. Okay. So this is going back a little bit just to remind you how, schematically, how lutetium works. The round blue circle here is the cancer cell, and on the surface of the cancer cell is the PSMA molecule. And the drug lutetium is actually this whole thing here. So it's an antibody that is, it is a radioactive lutetium isotope that is attached to the antibody, and this complex is injected into the veins, and this whole complex goes to the purple PSMA receptor, and when that happens, the lutetium gets released near the cancer cells. Couple caveats. It's made like a couple hours before injection. It only lasts for a few hours. So when the doctor orders it, you have to go in at a certain time. You got to get it on time, or else the stuff wears off really quickly. So the delivery it requires a little bit of good coordination, and you can't miss your appointment because that's $10,000 down the drain. All right. So this is a miracle at Hoag, where a patient had all these spots on his PSMA PET scan. This is the cancer, all these black spots. This is the kidney, so it's not cancer. And these are the parotid glands. This is not cancer. But almost everything else is cancer. Oh, this is the bladder. So it gets urinated out into the urine. So all the black dots is cancer. After one treatment, you've already seen a dramatic improvement. This guy had a PSA of over 100. After just 2 treatments, his PSA was 0.6, and everything disappeared. Okay. Wow. So typically, a patient gets 6 treatments. Is there a consideration to do less if one gets such a good response? You got to balance the advantages: less side effects, lower risk of kidney damage, but maybe 6 is better than 3 in terms of long-term success. So those are little things that doctors are working out. This is another patient, not as dramatic. He had 6 treatments at Cornell. I borrowed this slide from Dr. Tagawa. And he showed that, he had a lot of cancer before, and after 6 treatments, he still has a decent amount. So this is a good response, not an amazing response. They also did a CTC, circulating tumor cell count, and it also disappeared. So good response. And of course, there's some bad responses. It doesn't work. So 40% of people, this doesn't work. Okay. So these are some other targets. We don't need to go into too much because who knows which ones will be approved. PI5P4KA doesn't even have a real name yet. Is an enzyme target that they're targeting. BCL2 protein is excessively produced in about 10% of men with metastatic prostate cancer. It turns out that these people have a worse prognosis. There's finally a drug that targets this protein. And it turns out that this drug with enzalutamide is being studied right now, and so we'll see if it really makes a difference. One thing to remember is you could find a target, That's part one, but then you got to find the drug. So it takes a couple steps, and then you find the drug, and then you have to do the study. So that's why these things do take a while. This was a promising protein, this drug called NXP 800. It targets a heat shock factor protein, and we need to see if that works. This is pretty promising as well. Of the other surface targets that I've mentioned here, this is probably the most promising, the STEAP1 protein, and it might have a role of making immunotherapy work better. Okay, so a little bit more about combination therapies. Combination therapies typically revolve around hormone-type therapies, and I'll divide this in certain categories, and I'll try to go through the indication of each combination. So CSPC means castrate-sensitive prostate cancer. So these are men who basically Lupron does work, okay? And these are all metastatic patients when we use combination. So it turns out that if you have metastatic castrate-sensitive disease, and you use ADT, let's just say Orgovyx, let's not even use the word Lupron anymore. When you use Orgovyx and you combine it with any of these drugs in the first line, abiraterone, enzalutamide, darolutamide, apalutamide, these are all hormone approaches. Double hormone therapy does improve survival, delays resistance, delays progression of cancer in the metastatic spots. It turns out that if you use ADT Orgovyx with chemotherapy, you also get the same benefit. We actually don't know if ADT plus the first line or ADT plus the second line, which one is better. We just know all of them are better when you add it to ADT. But we do know that when you add chemotherapy and darolutamide to ADT, it is better than ADT and chemotherapy alone. So this triplet, not doublet, triplet, is used for patients who are a little bit sicker, who have high PSAs, high Gleason scores, lots of metastatic disease, and we're worried that the cancer is causing symptoms, and we want something to work fast, and we want almost a guarantee it will work. We would use the triplet therapy. So in the CRPC setting, castrate-resistant prostate cancer, we still have to use the backbone treatment, which is Orgovyx, Lupron, castrate, chemical castration. And we're adding these type of combinations. The PARP inhibitors with abiraterone, that's better than abiraterone by itself, as I mentioned earlier. This PARP inhibitor plus enzalutamide, that's better than enzalutamide by itself. They prolong the duration of response by about 100%. And now there's new research showing that back to the PSMA target, using that target plus enzalutamide seems very promising as well. This was data just released a few months ago. And this is data used before chemotherapy. Remember I said lutetium is approved for after chemotherapy? Well, if this data pans out, this may be one situation where you can use lutetium before chemotherapy. Okay, a little bit about immunotherapy. Background, immunotherapy I always say that people always use these lines, harnessing the body's immune system to fight the cancer. It just sounds amazing, isn't it? The immune system is primarily the T cells, not B cells, but T cells. And so we really need the T cells to step it up and fight our own cancer. Unfortunately, prostate cancer, we call it a cold cancer. The T cells don't really go to the cancer. So it's manipulating the immune system doesn't work that well in prostate cancer. It works amazingly in about 15 different cancers. Jimmy Carter's brain cancer disappeared for many, many years because of immunotherapy. A lot of melanomas, kidney cancers, just about 15 different cancers where it's very T cell heavy. Prostate cancer is not very T cell heavy, so that's the challenge. But one of the first T cell immunotherapy treatments was about 15 years ago. It's called Provenge. It's still being used, and it's used for people with castrate-resistant low volume, medium growing prostate cancer. So if you have a cancer that's exploding and it's very aggressive, Provenge will not work because it's not a really strong immunotherapy. But if you have metastatic disease, but not too many spots, Provenge could be used on the earlier side, and you tend to get a better benefit. Since then, there have been very few immunotherapies approved. The only other one is pembrolizumab, and this is otherwise known as Keytruda. The short answer is it gets those T cells into the cancer cells. But it turns out that it only works in a small group of men whose cancer has specific genetic features such as microsatellite instability, high microsatellite instability, high tumor mutation burden, or a defect in one of these genes that are part of the MMR family, MLH1, MSH2, MSH6. So in men with metastatic castrate-resistant prostate cancer, 5% of these men qualify for Keytruda. So 1 out of 20. If you do get it, the response rate's pretty good, about 40%. Okay. So if we can, the key is finding that 1 out of 20 patient who will benefit, because this drug has very little side effects. So, and testing for these mutations or these characteristics is very simple. It's part of a genetic testing panel, and we'll go into that in a second. The next generation T-cell immunotherapy treatment is called T-cell bispecifics. Amgen has a product that is pretty promising, and it's a drug that goes into the bloodstream, attaches to the T cells, and takes the T cells to prostate cancer cells that have the STEAP1 protein that I referred to earlier. That's another target. So this drug has been shown to work in about 50% of men in terms of the PSA dropping 50%. A quarter of these men, the cancer actually visibly shrunk. So it's in phase 3 trials now, so we'll probably get some data within 2 years. Many of you guys have heard of CAR-T. That's the easy way to pronounce chimeric antigen receptor T cell. The take-home message is T cells. The way the CAR-T cell treatment is approved for a lot of the blood cancers like lymphomas and leukemias. So the way it works is it's almost like Provenge. It's like a next generation Provenge. Again, it takes blood out from the patient, isolates their T cells, and once those cells are isolated, they actually are able to modify these T cells and inject them back into the patient. And the T cells are modulated and modified to the point where they hunt for specific targets. One of the targets is PSMA, but they're looking for other targets to create these bespoke T cell treatments for patients. So far, I'd say 20% success rate, so it's not great yet. We need more targets, and the side effects are fairly severe, so it's probably not something you want to do in the beginning of one's journey. So it's going to take a few more years. Okay, so let's switch the topic and talk a little bit more about less on the medicines and drugs, but let's talk about minimally invasive techniques, treatment options. One option is focal therapy, which you guys kind of know about, and you will have some lectures on them. Focal therapy the theme is when we treat prostate cancer that's newly diagnosed and it has not spread, we want to treat the prostate, and we end up removing the whole prostate, we radiate the whole prostate, we heat the whole prostate. So people always think, oh, the cancer's on one side. patients are not aware that we're not just treating the cancer in the prostate, we're treating the whole prostate. So kind of the analogy is when a lady has breast cancer, we remove the whole breast. So women have advanced the field of partial focal therapy of breast cancer. So we do lumpectomies. We don't take the whole breast. So finally, prostate cancer in the last 10 years is improving upon the lumpectomy approach to prostate cancer, removing part of the prostate. So there's various ways to do focal therapy: HDR brachytherapy, HIFU, cryo, TULSA-PRO, laser, etc. I'll talk more on the next slide. Another minimally invasive technique is SBRT. And the third minimally invasive technique is treating oligometastatic cancer. Back to focal therapy, this slide's from UCLA. These are 3 ways to do focal therapy. One is inserting little sticks into the prostate and dialing down the temperature and freezing the side of the prostate where the cancer is. This is using high-intensity focused ultrasound, like sound waves, and focusing it on the cancer. This is another method. The third method is using laser beams to direct into the cancer. Laser is not covered by insurance. It's fairly expensive, better for lower grade cancers, almost the cancers that don't need treatment. So that's kind of lower on my list. HIFU and cryo could be used. It's now FDA approved for both, and they're approved for low grade, medium grade, and in certain cases, the more advanced cancers. They're all pretty good. HIFU, these two, all 3 you could retreat. But the success rate is anywhere between 60 and 80%. So, it's not. So if you do HIFU or cryo, be mentally prepared. Oh, yeah, you get to retreat, but you could also say, oh, no, I have to retreat. So it's not as, even though there's less side effects, you really want to do this one and done and be over with. So my favorite is HDR brachytherapy. HDR brachytherapy is basically inserting little filaments into a patient's prostate. This gentleman's laying there playing on his phone, legs in stirrups, and he has these filaments. So he's awake. Filaments are inserted into the prostate. And on this machine, the doctor is 10 feet away doing remote control, releases radiation into these filaments. And these filaments deliver radiation. So it's a very precise treatment. So this is a picture of a whole gland brachytherapy from Dr. Albert Chang. So the filaments are here, radiation is released. The different colors refers to the different strength of the radiation. So all the strong radiation is within the prostate, and there is a little bit of a halo effect. The blue radiation is very low and is not dangerous. Okay. So different views of the prostate. But we're here to talk about focal HDR brachytherapy. This is a man, actually in our practice, he's 64. He had Gleason 9 disease, high grade. His PSA was 19. His cancer was only on one side. He's fairly young. He wants to have minimal side effects. He does not want to treat the whole prostate. This is the same cancer on MRI, and this is a ADC view of the MRI. So you see the spot right here? That's the cancer. Okay. And on PET scan, this is the brightness where the isotope accumulated within the prostate. So Dr. Chang delivered the high-dose radiation to the one side, the left side of the prostate, left side. This is a side view, and this is a frontal view. And all the red is the highest dose of the radiation, really concentrated. So the other half of the prostate did not get any radiation. And 6 months later, no more brightness, no more spot, and there's some scar tissue. That's it. So success. But yes, we need longer follow-up. And I think at this point, this gentleman's been in remission for about 18 months. So this is one example. This is another slightly older man. He's 74. His cancer's at the front of the prostate. Notice on the PET scan, it's not as, the brightness is only slightly more bright than the non-bright areas. This patient's Gleason score is only 7. The cancer's right here in the front. This is the cancer on MRI. This is the cancer on MRI. And after radiation to the front, this is the urethra. This is the front of the prostate, front of the prostate, front of the prostate. This was done over 2 treatments. And there's basically no more brightness. I haven't gotten the MRI yet, but we'll see. The brightness is gone. This is another person. Now, he had SBRT radiation already, and then the cancer still came back on the left side. And after radiation, he is in remission. The cancer disappeared after the radiation. I don't have an after slide, but one treatment basically took care of it. So, yeah, if I had to pick focal therapy, I'd lean towards the HDR brachytherapy. Another type of kind of minimally invasive is SBRT, stereotactic radiation therapy. I call it minimally invasive it's because, number one, it's just beam radiation. Number two, it's instead of going to the radiation doctor 28 days. When I started 20-something years ago, radiation treatment took 42 days to treat the prostate. Then it went down to 28 days, and then in the last couple of years, the research on 5 days has become more and more accepted. So very simple treatment, takes 5 treatments over a 2-week period. And the big trial that kind of put SBRT on the map as a potential standard of care is they did compare treatment with 5 treatments for SBRT versus 28 treatments with conventional hypofractionated radiation therapy for 800 men with low and intermediate risk prostate cancer. So 400 people got SBRT, 400 got 6 weeks, 5.5 weeks. Both groups had 95% control rate of the cancer, greater than 95%. So cure within the prostate was over 95%. It's really good. 1% of men in both groups had moderate to severe bowel problems, bleeding, mucus coming out, maybe stool incontinence, 1%. And probably because of Spacor, the hydrogel, that has decreased the side effect risk to about 1%. Both groups had some bowel problems in 10% of both groups in the short term, within the first year. Interestingly, for bladder, 6% of both groups had some moderate to severe urinary problems. And this is not incontinence, typically. It's more urinary frequency, urgency, maybe using a pad, but not like, wearing 6 pads a day. But it does turn out that for the short course 5 treatments, you will have up to 26% of men will have very annoying urinary symptoms the first year, as opposed to 18% of men will have annoying urinary symptoms if you did the 28-day treatment. So, and then the last side effect is sexual dysfunction. Both groups had about up to 30% likelihood at the 5-year mark of saying their sexual function has dramatically dropped. So in summary, the 5-day versus 28-day seems fairly equivalent, except maybe with the 5-day treatment, you might have more near-term urinary problems the first year or 2. There's a smaller trial that's accumulating patients studying SBRT 5 treatments versus radical prostatectomy, 60 men in each group. so far, the data looks like the most important data is 50% of men who had surgery were using daily pads at the 5-year mark with surgery. Surprisingly, 6% of men were using pads with radiation. So part of that is maybe, as we age, we tend to have weaker sphincter muscles, and that might contribute to needing a pad. But this is the major interesting data out of this study is the incontinence rate is dramatically lower, still there with the SBRT. SBRT is also used for the concept of treating oligometastatic disease. So, and this ties in with PET scan, which ties in with the PSMA target. So with PET scans, we're able to not only find the cancer and treat it, with the PSMA PET scans, we're able to find the cancer. So in this man, on a CAT scan and bone scan, we didn't know if there was any cancer, but on the PSMA PET scan, there's a faint little dot, and on a different type of view, they found the dot within the lung. And so this patient, instead of being relapse, no metastatic disease, he's a relapse with one metastatic spot. So in the past, when one has metastatic disease, we used to say, oh, it's too late. Don't even bother treating the prostate. You're incurable. Now it turns out that if you have very little cancer that even though it has spread in the lymph nodes, or in this case, the lung, if you treat the mothership and you SBRT the spot, there's still about a 30% chance of cure. So, and the great thing about SBRT, it's minimally invasive when we treat other spots in the body. So 3 to 5 treatments of this lung spot, probably 90% it will never come back. And if it never came back within the prostate, hopefully this guy's in remission for a long, long time, if not forever. Okay, so the next topic is diagnostic innovations in the last couple years. Again, we talked about PSMA PET scan being able to detect cancer. A little bit more about genetic testing. There's 2 types of genetic testing. One is somatic testing, and the other type is germline testing. Just to refresh everyone's memory, there is a lecture I gave during COVID, a video lecture about 3 years ago that was all about genetic testing. So you guys could refer to that for details. But basically, genetic testing or somatic testing is testing the DNA of the cancer cells. So you're trying to find out what characteristics or mutations does the cancer have that will allow us to uncover new treatments such as PARP inhibitors, such as Keytruda. So those are primarily the new treatments. Or other mutations that we didn't expect that work for other cancers. Maybe we could use a stomach cancer drug for prostate cancer because these genes have the same mutations. So the DNA can be extracted from the blood. There's multiple companies that are doing this. Guardant, Caris Foundation, Myriad. There's like 6 or 7 companies doing that. Tempus. Or you can also, if you had a biopsy of a metastatic lesion, you could test the sample that you biopsied of the tumor tissue. So that's testing of the cancer cells, somatic testing. The other genetic testing, which we think of when we hear genetic testing, is the genes of the host, the men who carry the cancer. So it turns out that certain men who have certain mutations, typically these mutations were inherited, they can respond to PARP inhibitors, immunotherapy as well. So you check for the host DNA. And for the host DNA, you could do blood testing, and you could also do mouth swabs. It turns out that when you do mouth swabs, you could also do genetic testing to see if SBRT is going to cause a lot of side effects. So they're using genetic testing not just for treatment selection, but side effect prediction. So again, I'll have you guys refer to the talk a couple years ago about genetic testing. So this is an extreme case where this is the same patient who had a bone scan and they found a couple spots. And he had a sodium fluoride bone scan and they found a couple spots. And then he did a PET scan and he found all these spots. So this is an extreme case, but this is an example of the advantages of PET scan. So it actually could make things look worse. So it could detect things that are minuscule, but on the other hand, it could give you the truth that things are worse than you thought. Okay. So double-edged sword. Okay, so last topic is artificial intelligence, AI. I'm sure half of the guys here are invested in AI stocks. But in the medical field, AI is getting a toehold into the field. And right now they're using AI to help radiologists interpret MRIs and interpret PET scans quicker, basically, and a little bit more efficiently and more accurately. These are a couple companies. They're helping pathologists look at slides quicker, find cancer quicker, and be more accurate. Okay. But the last two are helping patients, which is more important. They're helping patients predict how to manage one situation. And I'll go over this Artera AI system fairly soon. And the last category where AI is getting a role is it helps the radiation oncologists plan radiation better, hopefully with less side effects. So I borrowed this slide from the company Artera. I'm not a spokesperson, but they have a nice slide. Basically, this company looks at the biopsy slides and helps patients estimate long-term outcome, help a patient decide if he should do active surveillance, and help a patient decide if he should get a little bit of hormone therapy when he does radiation. Those are the three roles of this AI product. They take the slides. They don't need new biopsies. They just take whatever biopsy that was already done from the prostate. They look at it, and you get the results within 2 days. Okay? And this is what their report looks like. So they basically, pathologists, this is cancer, this round thing. A pathologist looks at this and say, this is cancer, this is a Gleason 6, 7, or 8, this is probably a 7. And what AI does, it looks at the cancer, but it actually looks at the pattern of the non-cancer around the cancer. And with that information, along with the patient's age, PSA, clinical stage, they could actually create a prediction AI risk score. And this is what their report looks like. So high, medium, low risk of metastasis, what's the risk of dying of prostate cancer, if this patient should go on active surveillance, and if this patient should get hormone therapy. So it answers a lot of questions to help the patient and the doctor decide what to do next. Now, hopefully AI will help us with picking chemotherapies in the future, sequence hormone therapy versus PARP inhibitors. So, help us decide if we should do PSMA PET scans earlier, or should we do lutetium earlier, later? So AI is just going to be a supplemental brain for the doctor. And I'm very optimistic that this will indeed be highly implemented in about 4 or 5 years. On that note, I want to end the talk, and thank you for paying close attention. No one fell asleep.
All right, thank you very much, Doctor. Excellent presentation as always. Amazing how much you covered that was clear. And I was like, oh yeah, he's summarized it so well and so much information.
Thank you.
Before we turn to the audience for questions. I do have a question. The images where you had A, B, and C were the different imaging, and the C on the right had like cancer everywhere. Sorry, which image do we believe?
That's a good point. I believe the PSMA. Yeah.
Okay, gotcha. And maybe
real.
those other spots are like the worst of those
exactly.
spots.
So, the tip of the iceberg was seen by the first two images, but the iceberg was really, the third image. So if you were thinking about, oh, let's just zap the prostate and zap that couple little faint spots on the first image, it kind of would be pointless because you missed another 200 spots. Yeah.
Makes a lot of sense. Okay, we're going to go. First hand I saw was back here.
Great presentation, thank you. Could you comment on the effectiveness of proton therapy?
Proton therapy is very effective and at treating the cancer within the prostate, typically. So that's when we typically use it. Yeah, it's very effective. I would say above 90% success rate at getting rid of the cancer within the prostate. If the Gleason score is higher, it might be 80%. If the Gleason score is lower, it could be 95%. So a lot of it depends on the Gleason score.
And side effects?
Side effects are probably equivalent to good old-fashioned SBRT, IMRT. Yeah.
Next question, Stephen.
Yes. You mentioned that there's a lot of clinical trials underway of these advanced medications, particularly the radiopharmaceuticals. Where are the centers of trial in the Southern California area for those, and who's leading the research?
So lutetium is widely available. So first do the lutetium, but if the cancer did come back after lutetium, the next trials would be like actinium. And for actinium, Hoag is doing them in Orange County. I don't know who's doing it at UCSD. UCLA has 3 trials going on right now. Lutetium is also being studied before chemotherapy. So for someone who's never had lutetium and you want to get it without chemotherapy, they're doing it. I think some trials close really quickly because they fill up quickly, but Hoag was doing them. Yep.
Great presentation.
Thank you.
Easy for me to understand, which was really important. You talked about minimally invasive therapy on one of your slides, and then the PACE-8 trial, SBRT versus surgery. And there was a 6.5%, I'm just kind of reading from a snapshot of your slide.
Yep.
6.5% incontinence rate out of that, I think 800 men.
No, 60 men.
60 men.
Yeah.
For SBRT versus 50% for surgery. Do you know if the surgery was open? Was it?
So 90% of surgeries now are robotic, maybe more. And so it's probably mostly robotic. Yep. A lot of caveats in that study. It's really small, so it was just kind of a proof of concept, just to give you an idea. There was a big difference in incontinence. Also got to remember, if you do surgery, some of these men have had to get radiation on top of surgery. So that's not a good thing. That's why a lot of the incontinence rates go up, because you get radiation after surgery. Okay.
Next question.
Thank you. A lot of most of your presentation material has been focused on soft tissue, and I have a unique problem in that I have a vertebra in S2, which was treated by proton therapy a couple of years ago, and I now have relapse. And the radiologist, Dr. Rossi, tells me you have already given the maximum dose to that vertebra. So I wondered if you could talk about alternative or additional treatments that are not radiation-based that you could go after something like I'm dealing with.
Yeah. Yeah, the concept is when you radiate a spot, including let's say outside the prostate, and if the cancer still came back within that spot, it is very difficult to do more radiation, very difficult to do more treatment. So there's nothing great around. There are some doctors injecting cement just to kind of support that area. There are some doctors doing scaffolding to prevent collapse. I don't have a great solution. So in terms of putting more treatment within that target, I don't have a great option for you. So this would be a case where you might be stuck with doing whole body treatment, systemic therapy, or adjust your systemic therapy that will treat the whole body and hopefully be successful. As that spot is part of the body, that spot will shrink as well. And it might not hurt to get a second opinion. There are some places that could do more radiation, but it is a difficult situation.
Next question.
What about
Oh, go ahead, Larry.
laser or thermal or cryo? What do you think of those as possibilities?
Yeah, I mean, not much data. And you almost got to remember that when you, let's say this is the vertebrae and there's a cancer in there. A lot of cancers are, we call them sclerotic cancers. They're dense cancers. They're cancerous, but they're dense. It's not like a hole or anything. So if you do more treatment, you want to do more treatment and get rid of all of it. If you do more treatment and only get rid of part of it, the other part's going to replicate and come back. And then the more you get rid of, you actually kind of remove the scaffolding support of the vertebrae. So I'm not sure I would do laser or any other secondary treatment.
Thank you very much, Doctor. It was a great talk, very informative. Can you just talk briefly, for those that might be on active surveillance, about Decipher test? I know you talked a little bit about genetic testing, and how much weight do you give the Decipher test with that score?
Yeah, Decipher test is basically looking at genetics of the cancer, but it is the genetics of the cancer within the prostate that you check during a biopsy. So, I would say PSA, MRI, ultrasound. What we see on the MRI is very important. That carries a lot of weight. The Gleason score carries a lot of weight. I would say in 1 out of 10 people, the Decipher will nudge us one way or the other. But for fun, maybe do the AI.
Hi, Dr. Lamb. My dad, Coop, here has been on a certain regimen, but I really enjoyed your presentation. First time I've heard you. My dad's been steady on Lupron for the ADT and bicalutamide, Casodex. They switched him to Xtandi, and over time, his PSA and testosterone both went up. We had a hard time figuring out what to do. The doctor's notes, I came back a couple months ago, I went through and they mentioned the PARP inhibitor, olaparib, and then the Talzenna at the time, even though they were already FDA approved. Right now, Dad's on the bicalutamide and the Lupron. Yeah, and we had to fight for it, but we got it. First generation versus second generation is always a big discussion. But right now, if we were to add to the Lupron and bicalutamide olaparib and see maybe how the receptor, that it does kill off some cells, is that something that is considered? He's got castrate-resistant metastatic.
I add one thing. The Xtandi PSA started rising, and I went back to bicalutamide, and it started going down.
Okay. So when you were on the Xtandi, did they remove the Lupron, or they just continue the Lupron and substitute? Interesting. So that's a very interesting case where the better drug worked worse. So But that's a whole nother discussion. In terms of should one add olaparib, was he genetically tested and he qualified? Okay, yeah. So is there a lot of metastatic disease?
We are going to have a PSMA
Yeah,
next month.
okay. And the only reason not to just say, oh, sure, add it on, it has side effects.
Yeah.
So quality of life. So that's something to consider. Yeah. Oh, the other thing I want to tell everyone is don't let the cost of these medicines impair your decision, because if you have Medicare, the new law is the maximum out-of-pocket is $2,000 per year. So these insurance companies, they say, oh, here's your first month, that'll be $1,000, please. They don't tell you that the $1,000 ends at month 2. So patients are thinking, oh my gosh, I got to pay $12,000 a year. Forget it. Get me back on Casodex. So make sure you're aware of that. Okay. So olaparib, $150,000 a year. That's how much this drug will cost. But your out-of-pocket should be $2,000.
All right, next question. Let me try something else before Larry again.
You talked earlier about the HDR brachytherapy. Did you elaborate on the side effects? And a little bit on the wild side is social media has a lot about ivermectin and fenbendazole. And is there anything being researched on that, or is that just a lot of hype?
Very little research. The little that there is gets amplified. So, and a lot of these are clouded by other treatments that are not disclosed. So I'm not so sure about that. In terms of side effects with HDR, primarily it's urinary annoyance, frequent urination, getting up more often at night, urgency, when you got to go, burning sensation. Usually abates after a month, maybe 2 months. Sexual dysfunction, anything that attacks the prostate can have some collateral damage sexually. So if you do focal, it's probably 20%. If you do whole gland, it's probably 40%. Sexual problems.
Is it being offered everywhere? Or?
It is a technical treatment and it doesn't pay very well. So it's not offered everywhere. But UCLA has an amazing doctor there. I think, well, they do brachytherapy, but I don't know if they're doing HDR brachytherapy. They should be able to, yeah.
Next question. I will let Larry ask another question. We'll go to him first.
Thank you. I have a question about the brachytherapy, and I'm thinking about the photograph you showed of all of the. So are all areas of the prostate surface equally accessible for that treatment?
Yeah. So the wires are inserted in the area below your scrotum and above your anus. It's called the perineum. So yeah.
All right, going back to Larry here.
There's a peculiarity about this S2 relapse that I have, in that the SUV max has increased from what it was a year ago. However, the diagnostic CT that goes with the PET CT shows nothing. There's no target. I wondered if you'd ever run into that, and I really don't know what to make of it.
That's a good point. Especially after, I have seen, not uncommonly, things look brighter and yet the CT doesn't look worse yet. And that's kind of the double-edged sword regarding PET scans. It can detect cancer earlier when the other scans don't. So not uncommon. Do you do, excuse me, does one maybe do, you got to look at the whole picture, maybe do an MRI that is a better way to look at the vertebrae in detail as opposed to a CAT scan. maybe do it sequentially. Sometimes the passage of time will kind of give us clarification. And then the third option is put a needle in there.
What about a diagnostic CT?
What's a diagnostic CT? I think,
It's more sensitive, the one that, the CT that goes with the,
oh, I see what you mean. So do a CT that specifically looks, yeah, you bet. I would say a diagnostic MRI is typically a little bit better. Yep, sure.
All right, another question down here.
There's a chance I don't have to go till noon, right?
I'm on active surveillance. My father-in-law has his prostate removed. He just finished the radiation treatment, but his PSA went up after that. Is that expected or not?
Well, when you do radiation after surgery, your goal is the PSA not to go up. So sometimes you go into radiation thinking it's probably not going to work. Then when the PSA goes up, you're not surprised. But I don't know in your case, what were the pre-radiation predictions? So if indeed, it almost doesn't matter what we're thinking in our mind, but the fact is if the PSA is going up, that means there's still some cancer in the body that makes PSA. So prostate cancer that makes PSA, you can have prostate cancer in your earlobe and it makes PSA. So it doesn't tell us the location of the cancer. It just tells us the presence. Yeah.
Doc, thanks for the presentation. I'm concerned about, you know so much. I'm concerned about finding somebody that knows as much. If I needed some treatment, how do we do that? Where do I do that? What do you recommend?
What do you think, Gene? So you could, sometimes you have to just attend this group. You learn a lot. And whatever you learn, you just have to bring it up to your doctor. And it's surprising. I bet you guys can attest to that, how often the doctors that you guys see will say, oh, yeah, let's try that. Oh, yeah, let's do this.
Okay, you're an oncologist?
Yeah.
You are?
Yeah.
Is that the kind of doctor we want to get, an oncologist that can cover?
I think so.
But just to clarify, so typically a urologist is a surgeon, and then you have radiation oncologists that specialize in radiation, but you are a more general oncologist and cover everything.
So, we're kind of unique in that we see patients who are newly diagnosed and we help them make their first step, kind of like in a support group. And then if they relapse, our role gets bigger on how to manage the next 10, 20 years. And we see a lot of patients where the situation's a little difficult and patients need more opinions.
And do you find that insurance companies typically, like I recall with my treatment, I was first sent to a urologist. It's like I did not even see an oncologist until after it was determined, oh, surgery failed, you're stage 4. Then I even then had to be approved to see the oncologist that I even got to. But it seems, doesn't it make sense to, especially with all the genetic testing, all of the opportunities for, even as you were saying, oh, there's a swab test to see whether SBRT is a good idea. That's the first that I think that this group has heard that. It seems we should be seeing somebody like you right from the start, even before the urologist.
So it's common that your journey starts with the internist who says, oh, your PSA's up, go see a urologist. So that's how the urologists get into your lives. And then they need to do the biopsy, and sometimes they'll order an MRI. So that's how the relationship starts. In the past, pre-Dr. Duke Bond, or since Dr. Duke Bond 15 years ago, we see a lot of patients. Some internists actually refer to us because we do the biopsies. So that's how the journey with us starts if you skip the urologist.
I've read both your books by your colleague, and is there a way of seeing you that kind of follows this question without going up to Marina del Rey? I mean, through, well, not that
I get
I'm
it.
opposed to that,
I
but
get it. Yeah,
they have.
I get it. I drove down yesterday.
Telemedicine.
Yes. Well,
Through Zoom or Facebook.
yes. So typically so everything's in flux. So Medicare, which determines what insurance companies eventually do, have been covering virtual meetings, and that helps with. So that actually expands our footprint. But Medicare is not going to cover virtual meetings starting April 1st. This was a COVID exemption that they were covering virtual meetings. Now, they were going to stop January 1st, and then somehow it got magically approved for the next 3 months, but that's ending April 1st. So after April 1st, we'll find out if Medicare is still going to cover it. So if it's covered, then, yeah, I mean, we do a lot of virtual calls.
And I say that that's how I use him now.
Yeah.
And Medicare covers it for you?
Yes, but April 1st, we don't know, you know.
Yet.
That's why it's speak to your congressman.
Being there for 17 years, it's worth it, whatever.
So,
right.
yeah, I hope it's covered.
Oh, okay, we got a couple more questions here. This helps with for the video.
Thing is that if you do, and I would highly recommend Dr. Lamb, and worried about that, put somebody in your car seat and take the fast lane, because Gene and I talked about this, and it's to me it was really worth it, really much so. So anyway,
Thanks for that. We're going to have two last questions. We're going to let Dr. Lamb go or be available for less formal questions.
How common is neuroendocrine cancer after years of Lupron?
About 5%. So a lot of it has to do with the longer your cancer's contained, the more time it has to mutate. So, when we didn't have all these new targets and new receptor blockers, people died of regular prostate cancer before the cancer cells mutate. But as people live longer and longer, we're seeing weirder things about prostate cancer. It's going to the lungs, it's going to the liver. It mutates to neuroendocrine. In terms of newly diagnosed patients who've never had Lupron, it's probably 1 or 2%.
Quick question on AI. The Artera AI, you mentioned it be a promising tool for the doctors.
Yeah.
Is it something that you have to consider for coverage, speaking of all this Medicare coverage?
Yeah. I mean, I forgot how much it costs, but Medicare does cover it. Yeah.
All right. Actually, is Gabby here today from Artera? I think her name was Gabby.
Yeah.
She was going to come to one of our meetings.
Golly, she's aggressive.
Oh yeah, she's already contacted me. She wanted some of your time, some of the time today at the meeting to present, and I was like, "We're giving Dr. Lamb every minute." But we're working on having Artera come in and talk about their new product sometime in the future. She might be here actually on site either today or in a month or two.
I have to reprimand her.
Oh, okay.
This is not a sales pitch. I mean, it's so.
That would be good to clarify to her.
I got a comment to make.
Sure.
We've been coming here for quite a few years. And with my husband's treatment, we took Aaron's advice at heart that each person has to be their own case manager, because with him, his cancer came back, but he had asked for an oncologist before the urologist told him to. So I think, that everyone should be thinking about that and evaluate their own situation.
Good. So, thank you for saying that. I'm not giving excuses to urologists, but back in the day, all we did was chemotherapy, And so a lot of urologists say, oh, I'll manage all the Casodex, basically. And then when the patient needs chemo, then we'll send the patient to the oncologist. But as you guys know, there's so many non-chemotherapy options, and urologists are busy. You know, they're the busiest doctors around. They manage so many, you know, men and women. And they have other cancers that they have to manage, and then kidney stones and all kinds of fun stuff. So, yeah.
All right, let's have one last round of applause for Dr. Lamb. Incredibly useful having you come down
Great.
here. Thank you so much for that.
Thanks, everyone.